The SGR fix came along, and I was pretty excited about the SGR fix when it first came out, but then look more at the details. It's more like taking your dog to the vet to get it fixed. So I'm not sure it's going to be best for us, but it does have a provision in there about bundle payments, and it's pushing doctors toward alternative payment models. And if we do more than 25% of our practice in an APM, then there are financial incentives. So it's definite that the government, the payers, are pushing us toward this model. So it's not just coming, it's already here. So why are we getting pushed into this? We've been a fee-for-service for a long time, but most of the payers feel like the fee-for-service is somewhat uncoordinated, that there's no way to control cost. Government noticed this a long time ago, back in '83 when we first had DRGs. That was our first bundling for payments to a hospital. It didn't include physicians, only hospitals. Then in '97, we had fixed payments for inpatient rehab and home health, because what we were doing at that time, we were getting people out of the hospital earlier, moving them into inpatient rehab so our hospitals would do well. Then the government's not catching on to all that because skilled nursing stayed per diem. We've shifted them all to skilled nursing. Costs are still up there. And looking at all the studies of patients that go to skilled nursing, inpatient rehab, and those that go home, there's no difference in outcomes. It's all the same if they go home the same day of surgery versus 2 weeks in a rehab. So this is what they're pushing us toward. If your hospital is on the far left of the screen, you're going to be pushed down to where all your patients go home. And our goal at our hospital is now all of our patients go home, preferably in 1 day, at least in 2 days, maybe with home health, but better off if they just go to outpatient therapy. And then why do they pick on joint replacements? Why? It seems like they're always picking on us and cutting our fees and cutting what they pay us. So why pick on joint replacements at this time? Well, we consume a lot of the dollar that Medicare pays. We're a big target. There's a big potential for cost savings. There's less risk for providers in the arthroplasty, and there are significant cost variations across all hospitals with no change in outcomes. There are different models of bundle care, bundle payments. The prospective is a single payment that goes to a provider group, whether physician or hospital. The other is retrospective, where the bonuses or penalty is paid based on the delivery of care and what goals we met in the delivery of care of that patient for that specific condition, which leads us to gain sharing or shared savings. Hospitals can pay a physician a percentage of the savings on the care of that patient. And Medicare even allows us to make up to 50% more based on our fee for a total joint in cost sharing. And with us in our hospitals, since we own that, we share in the savings, but in the nonprofit hospitals, they also involve in gain sharing with their physicians who cooperate with them and align with them in the same goals in treating the patient, plus saving money. We have a new law in Arkansas. It's been present for about a year or so, where they're pushing us also into the bundle care payment models. It involves Medicaid and the commercial payers. Among other things, is the hip and knee replacements involved, but hip and knee is all that involves orthopedic surgeons. It runs from pre-op to 90 days post-op. It's a retrospective payment. And the one we're doing right now, we are getting paid fee for service for the patient care. But at the end of the year, they look at how we've done, what goals we met, and we get a bonus or a penalty based on that. So far, we've done real well. I think all of our doctors have gotten bonuses since we started this program. So right now, we're meeting all the guidelines that they've set up. So what we're trying to do in bundle payments is align the physician and the hospital. So we're just like this ladder, we're all together and going in the same direction. There's some consequences that occur when we get aligned that are expected. There's a higher margin of patients going home. We also have to bear the financial risk for the post-acute care and also for any readmission for a problem related to the knee or hip surgery. We also definitely limit the post-acute care choices for our patients. There's some unexpected consequences too. One's an incentive to skimp on care, patient selection, or even just patient deselection. And also, how does that pertain to peripheral technologies in our hospital? And we looked at all of these and the cost and the benefit, because I like gadgets, I like working with all these things, and I did navigation for a long time. Even before bundling came along, looked at my navigation patients. The alignment really was no different than my normal alignment using the normal guides. So I stopped doing navigation because it increased the cost to our hospital. I looked at the ortho sensor, balanced that in surgery. I couldn't tell a significant difference in the balancing with the ortho sensor. It took a lot of time. It added about $500 to $600 extra per case in our hospital. We looked at patient-specific cutting guides. I've used those. They're simple to use, but then that involves getting an MRI or CT of the patient's knee, hip, ankle, then the cutting block's made for us. That's not significantly different either. Not a great benefit of that, and also a significant cost. And then the robotics came along, and the robotics came to our hospital. The company visited our hospital at about the same time we were going into the bundling. We looked at the benefit of it. The technology's good. However, looking at the x-rays on the robotics knees, on the unis, compared to our eye-balance unis, not a significant difference. We think our patients are doing just as well without the robot, but we couldn't pass the cost-benefit analysis for any of these technologies to continue to do this in our hospital. So now we don't do any of these peripheral technologies now, and we're still getting good outcomes with our patients, and we're having much lower costs than if we had all of these involved. The other thing we did is we standardized all our inpatient protocols, and we've also started to standardize our patient education. I'm sure most of you are doing that with your patients, but the cornerstone that we found right now that we're starting is our care partner. We have a patient, before they come to the class for their education, they identify either a family member, a friend, someone who can be with them at the time of surgery and help them post-op. They come to the class with them. The patient and the care partner both receive instructions of what they're supposed to do, how to get the house ready, how to get meals prepared. The care partner's in the hospital, and the care partner comes in. They receive a band so that everybody in the hospital, all the staff know that this is a care partner. They're included on all the education, physical therapy, medication. Everything this patient's going to do, we have the care partner involved. Our goal is that every patient goes home. Nobody goes to skilled nursing. Nobody's going to go to inpatient rehab. So now we have the patients lined up with us, and we have, instead of an unstable ladder, we have a three-legged stool that's going to be much more stable with the hospital's physicians and the patients all aligned in the same goal. But we want to go one better. This is working real well, but now what we started is our four-leg stool, which is much more stable, and we are now working with an industry partner to help us with our patients. And you probably guess which partner that is. And we started working with Thrax. I think the same qualities that make Thrax a Forbes top 100 company to work for also make it a top company to work with. They do help us treat our patients better. They promise and deliver. They're an orthopedic company. We've just opened our Synergy arthroscopic suites. We use all the sports medicine line. We use the biologics, and now, more recently, the arthroplasty, especially the total knee is what I'm doing now. It's a simplified system, very reproducible. We're getting excellent patient results. We also have the shoulder coming out, patellofemoral uni, and then in the future, we're going to have a total hip also. So this is a fantastic opportunity for us to work with Thrax and to provide better care for our patients at a good cost, at a time when it's really challenging to take care of arthroplasty. And most people I talk to say, well, they're thinking about not doing arthroplasty because it's not going to get paid in the future, the reimbursement's going to get cut. I'm more optimistic about arthroplasty right now than I ever have been, because the companies like Thrax that work with us, that our bundled payment plans are working for us. We're able to control cost. We have help from industry, help from our patients and the hospital. And I think in the future, we're not just going to survive this bundle payment, but we're going to thrive through that, and I think you can too.